Hello, everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. I'm excited to bring you one of my favorite people to interview. It's Peter Tippett, CEO of CareMesh. Welcome, Peter.
Thank you. Nice to be here.
Yeah, so before we get into our topic, talking about interoperability, the latest CMS final rule, etc., tell us a little bit about yourself and CareMesh.
Sure. Well, I started my life as a tinkerer and then became a doctor and wound up building software. I'm best known for doing the first antivirus product. This is computer antivirus and eventually
Amazing.
became Norton antivirus. But I had telemedicine or mobile medicine with an Osborne computer in the remote Pacific before there were PCs, and
That's
an
amazing.
early EMR based on dictation. And several other companies along the way. And lately, I started this company called CareMesh because I, like so many doctors, have just never gotten the comfort. We never got the aha out of EMRs or HIEs actually making communication work. All the things that we dreamed of making, of having computing help us get our jobs done, talk with other doctors, exchange medical records, all the rest just wasn't happening despite decades and decades of trying. And I was on the PTAC, I was on the standards committees, I was on the policy committees, and I'm just embarrassed that so much of that didn't work out. And so I started CareMesh to try and solve a half a dozen problems all at the same time on a global scale, with the hope that we could put together a single platform that could solve interoperability with medical records, solve messaging, and solve notification, all in the same platform, no matter what the other end had installed, bought, or didn't buy.
Hmm. Well, I guess that's what a tinkerer does when they go to med school, because a doctor doesn't allow you to tinker nearly as much as technology. So I guess that makes sense from a career path. I think back to one of our conversations that we had maybe 5 or 10 years ago, and we were talking about it. And I remember, interestingly enough, you said to me something that I'll never forget. You said, "Why can't we just start with connecting the endpoints? And let's share whatever we can share. And let's start with that." And I thought that was a fascinating insight. And sadly, we're still dealing with some of that today. In fact, in the latest CMS rule, it's going to require hospitals to do some stuff with data sharing. Can you dive into some of what the new rule requires hospitals to do, and what's the timeline they need to be thinking about?
Yeah, so there are two federal rules and a whole bunch of state rules that have something to do with data sharing. What has been called meaningful use, and then
Right.
MU2-3 is now called promoting interoperability. And 40% of the points, and you need 50 points, so 40 of the 50 have to do with what they call closing the referral loop or digital transfers of care. And that gets you 2 or 3% of your Medicaid money as a penalty, Medicare money as a penalty. So it's a significant hit. That's live now, but the threshold on interoperability for digital interoperability went from 10% of transitions of care outside of your network had to be digital to now it's 50%. It isn't quite 50%. It's getting these points, but most hospitals interpret it as 50%. And despite everybody trying for decades now, most hospitals aren't even in the teens. 10 or 20% is rough for digital transfers of care outside of their own organization. At the same time, this whole notion of notifications has been really important, not just to the regulators, but hospitals and doctors and everybody else in the ecosystem just understands that it'd be nice to let the other doctor know that their patient was in your emergency room or hospital. Seems
Yeah,
like a thing. Uh,
amazing. Huh?
so the condition of participation, or the final rule, which was became final a few days before HIMSS didn't happen in March this year, was going to come due in September, October this year for the parts that we care the most about, but that has been delayed to May 1st. Has 7 criteria, the 7th of which have to do with notification of practices or practitioners, primary care providers, or their practices. And it requires, and I'll read the exact language because it requires that hospitals make a reasonable effort to send notifications to all primary care providers or their practices. And the reasonable effort is a legal term. Legal people start with best effort, and then
Uh-huh.
everybody talks them out of that. Says, no, require best effort. So
Yeah,
the
just
next one
reasonable.
down is reasonable effort. And so a hospital will have to argue. Any hospital that has ADTs running on the inside must do this. So that's 90+% of hospitals. Um, and making a reasonable effort to notify all primary care providers or their practices is the standard. Um, I've been involved with lots of health information exchanges, and this is a core capability of most HIEs. It is the thing that actually gets done by a lot of HIEs.
Yeah.
But even the best of HIEs are skirting in the 70% range of notifying primary care providers in their state or region. And that's largely because most HIEs sign up the hospitals first, and then they have a hard time getting to little primary care providers. It's also hard because whether it's an HIE or some other vendor, the usual way that notifications are turned on is by talking to the destination, this one doctor practice, and say, all you got to do is install this software and give me the list of all your patients every month, and then it'll be great. Then we'll notify you if any of those patients are involved with something. Well, all you got to do is give me a list of your patients every month and install some software. Sounds like a giant pain in the, by these doctors. And the question, then they say, well, maybe that sounds like a lot of work. And it turns out that getting smaller doctors or remote doctors or practices to get engaged with HIEs has always been the biggest problem of an HIE. Hospitals have the same problem. They've got to get the outside provider to engage in something. And that's been a real trick. And so at CareMesh, one of the things we tried to do was build a platform that didn't require anything of the outside provider, the same way FedEx or UPS doesn't require anything of the destination. You give it to FedEx and they get it where it's going. You might say, but my grandma lives on an island, you're going to need a boat. Like, that's the problem, right?
Yeah, we'll figure that out.
They get it delivered. So that was the goal of CareMesh, and we've been wildly successful, way more than I expected on that. We did a launch with Tampa General Hospital in Florida, which published the fact that we did that over the summer. And in the first 90 days, we've delivered 99.6% of every single notification that or ADT that of every patient that was in that hospital. That was 97+% on the first day, and it's
Wow.
into the 99.9 or so in the most recent month. And so if you think of states where the poorly run HIE is maybe in the 40s or 50%. The great HIEs are maybe in the 70s. You don't see these published because nobody wants to publish non-success, right?
Yeah, that's interesting.
And you can blow right through that and give people not just the notification, but the actual medical record essentially 100% of the time, and get them engaged with the hospital so that other good things can happen. That's really cool.
Well, I think it's interesting because on the one hand, you're like, are we sending a bunch of notifications to providers who will say, what do I do with this? So I think that was the other problem, engaging those providers. Like, okay, it's great to know that my patient went to the ED and was admitted or whatever might happen. But then they're like, what do I do with it? And I think there's even some piece of, okay, am I liable now? Because I know that information, does that mean I need to reach out? I mean, I think there's a lot of questions for doctors. So you asked them to give you their full list of patients, which also could be a security or anti-competitive issue, right? And you want me to install this software, which, oh, it sounds easy, but and then now you're sending me a bunch of things that I'm not sure how to process. And so I think it makes sense why many doctors said, I'm not sure about this. But so I mean that seems like an interesting challenge. Are there other challenges you think healthcare organizations are facing really complying with these rules?
Well, they are really, really hard to comply with. Reasonable efforts to reach all is a scary thing.
Yeah.
When I've talked to hundreds of hospitals about this, and most of them have been putting people on call teams. When this first started in the ER, we
Hmm.
worked at a California hospital that just hired 10 people to show up at 7 a.m.
You're gonna bootstrap it with people, huh?
Yeah, we would start dialing at 8 a.m. With the results of what happened in the emergency room and the hospital discharges from yesterday.
Wow.
The rule does not require that the notification be electronic. It just requires that it be delivered. So it could be delivered by phone or by fax or by direct or by fire or by some direct network that both ends use. None of those are required as a particular standard, which is nice. Just getting the notice there. But of course, as a doctor, it's one thing to know. We worked with an HIE that did great, as good as notifications come. Um, but the doctor at the other end, to get the notification once it happened, they'd get a notice, say by fax, that their patient was admitted, but it was very cryptic. It was, you've got a notification, right? Then
Go
it
sign into the portal or something.
the HIE, then you got to prove that you are who you claim to be. Then you got
Uh-huh.
to download a file. Then you got to unencrypt the file, and then it looks like a spreadsheet with one line per patient. And it might have the patient name or it might have the patient ID number. Then you got to take that and put it back in the HIE to get something like the record. It was 7 steps like that to get anything useful. So I don't think the problem for the destination doctor has much to do with worrying about liability. It's mostly a PIA. And
Yeah.
we give people too much pain in medicine as it is. In the care mesh case, we figured out how to not only give them the notification, but we include the medical record with the notification, even if it shows up as a fax. So we've got that summarized. So they not only know who the patient is and the problems, meds, and allergies, but also the summary of the discharge and the account. And if they want to get it digitally, or if it could automatically be digital, for example, if Direct is working or if they're part of some other network, then the CareMesh platform automatically shoves it into that place. So for Tampa, for example, we're past 60% of all notifications go digital into the EHR of that
Nice.
patient, of that doctor. Whether they've ever figured out how to make digital things work or not, we see that as our problem. And to fix the protocol problems that are the Epic sender and the eClinicalWorks recipient, or the Cerner sender and the Athena recipient, there's little differences between the protocols and little rules about how Direct works and little rules about how records should show up, so that in the end, even if both ends have the right protocols running, it's only about 20 or 25% likely that a message from the sender will actually arrive and be available to the recipient, even if it's all theoretically working. So fixing all the little bumps in the middle to get the header right and for the recipient, even though it's not right when it's leaving the sender, or to get the message formatted, get the encryption right, or the compression right, or there's a bunch of different things that can be different and still be within the spec, and all of them cause problems.
And is that why the EHRs haven't made this happen? I mean, I think many hospitals probably look at it and say, oh, the EHR is just going to solve this for me, which I think is probably an incorrect assumption for most EHR vendors. And it's probably because every EHR has their own flavor of interoperability on that standard. Is that why? Or, shouldn't the EHRs make this happen for hospitals, or is that just not their place?
The big EHRs do a pretty good job of, they've got a portal that the doctor can log into and get at the record. They've got a way to push a notification to those doctors. It puts the onus on the hospital to build a directory of all those doctors and to find ways to connect with them, whether it's direct or fax or fire or something else. Most of them can't toggle back and forth and chase down all the possibilities of connection. None of them do anything automated or change the format of the document or change the content. Some EHRs will accept a message without an attachment. Some will accept an attachment only if it's a CCDA. Some will accept it only if it's a certain kind of CCDA. Many of them will accept a CDA, but not the note that came with it. The note is thrown away, the CDA is kept. There's all kinds of problems. So the note might say, ignore everything in the CCDA. Here's what you really need to know.
Yeah.
So this notion of sending medical records as CCDAs or XML files, I love it. I think it's a great thing. The good news is that EMRs can deal with them. But the bad news is that there's enough variability that you have to understand the difference between the sender protocols and the destination. And there's not much in it for the EHR vendor to figure out the 100 destination EHR foibles.
Yeah.
It could be an installation thing, it could be a permissions thing, it could be something's turned on or not. It could be that something should be turned on but isn't. It could be that they've never designed that in. Some EHRs don't have any notion of a messenger, so how could you put a message in a place that doesn't exist?
Yeah.
Others have them, but they're not turned on. You know, it just goes on and on. And Direct itself has foibles as well. It's a good protocol, but there are if then else choices. And if the destination chooses one and the sender chooses another, you wind up with messages that bounce or get in a dark hole or something. So the beauty of a service provider like CareMesh in the middle, we've got a service called Delivery Manager that automatically tries all the things and learns about the destination and does some AI and figuring out whenever we see, oh, here's what worked for the other eClinical works. Let's try that for this eClinical works.
Right.
And if it works, then we'll make that the ECW destination rule to go with. But if it doesn't work, the automation will try different things.
Back.
And in the end, in CareMesh, for that, in the first time we sign up customers, 2 or 3% of everything fails. But we have a team that gets notified, and that team gets on a phone and calls the destination and says, look, this hospital is trying to send you some medical record on your patient, you know, Billy Bob. Let me talk to you about how to make this work. And we wind up, that's how that team winds up making the directory get better. CareMesh has a national directory that includes all the possible communication methods with every doctor or hospital or practice in the country. Of course, you have to have that. It doesn't, you have to be able to reach a person, whether they're a person like Dr. Smith or whether, you know, Sunnyside Clinic on Main Street. Or whether it's the pulmonologist at Sunnyside Clinic, you know,
Sure.
there's
a lot of details.
There are different ways people want to make the message go out. They're trying to get a referral, they're trying to get a notification, and the recipient needs to have a say in this. You know, Sunnyside Clinic might have 5 clinics, you know, and Dr. Smith really works on Park Street, right? So wouldn't it be nice if the recipient could say, yep, you got it to Sunnyside Clinic, but our pediatric referrals all should go to the pediatric referral team. That's either this direct address or that fax or this FHIR endpoint, and let them update their recipient preferences. And all of that should be free. None of it should require anybody install anything or buy anything. So in the CareMesh case, we don't require any software of any sort, no install of any sort, nothing to purchase or buy. We guarantee delivery to every doctor or practice in the country, no matter what it is. If you want to send an X-ray or an MRI or a notification or an actual message, all of that works.
Yeah, that's impressive. It's a lot of work, I think, to get it, because there is such a diverse. I mean, I just throw in the patient as well. What if the patient says, oh no, I work up in the north, so even though I live in the south and the clinic's close to me, I want to go to one by my work. So there's so many complexities there. You know, as you look at it, you know, you've obviously been on a lot of the committees, you've been working on this problem a long time. Will the regulation and these efforts finally make healthcare interoperability a reality, or where are there still some holes that need filling?
Well, it's nowhere near a reality now. You know, the patient stories are where you hear it. This whole notion of we ought to give the medical record to the patient so they can carry it where it needs to go is crazy. It's like giving me the schematic diagrams for my automobile so I can carry it to the next shop. It's nuts, right?
Yeah, I mean, I think it works for, you know, what, 3%, 5% of patients, and that's great. And I think we should do that, right? But yeah, it's not solving it for the other 97% that say, I don't give a rip, or I don't understand that, I don't need to use the tech.
Required of my mother-in-law to to figure out how electronic medical records are supposed to work, or to unzip something that came from a CD and oh my God, or to haul around the, no, so making the patient part of the equation, I agree, is absolutely should be available if they want it, and it should be wildly simpler for them. But even they can get the data mainly from the big hospitals and not from their private practitioner, because the private practitioner is not running FHIR, and they can't use Apple against something that's not running FHIR, and if it didn't, then get in, and on and on and on. So that part doesn't work, and it needs to be fixed. On the real interoperability side, interoperability for everything else in the world is really three different things. It's notification, somebody wants to talk to you.
Yep.
It's messaging, and it's sharing of records or files. So when my boss says, I'm giving a big speech, I love the way you did it last week, can you send me the PowerPoint? I say, sure. Right.
Uh-huh.
The boss doesn't dig through 3,000 people's hard drives and the whole company to find all PowerPoints and figure out which one was the one that would most be like the one that he wants to give, next week. That's stupid, right?
That's interesting.
Somebody, right? Who knows? And that somebody says, yeah, this is the one. And by the way, I learned after I gave the speech that the way I presented slide 5 is really a better way to do it. And here's a little hint on that. The boss can come back and say, that's great, thanks for that, but slide 7, I got a question. Would it be better if I said it this way or that way, and kind of use Billy Bob's piece in that place? This is how we do collaboration. We take documents or files or records or medical records, whatever it is, and we give clues. Doctors call this the bullet, right? Doctors would love to get the bullet from the other doctor, which is the one paragraph, the 3 sentences, the 7 sentences of what's going on and why, all compressed into a minute or less.
Yeah, for sure.
That's what doctors want. If doctors could only get one thing from the other doctor, it would be the bullet, right?
But instead, we're sending this big reimbursement documents that the bullet's buried in there somewhere, but it's not easy to consume.
The documents don't contain the why, or what I call the subtlety, right? The reason I changed from this blood pressure med to that blood pressure med, and why we've chased through 5 different ones, is not likely to be much of the record, sure, right? But it's part of the bullet, right? She has trouble with pink pills. What? Well, pink just turns out to be a problem, right?
Yeah, whatever it might be.
So
there's all
they get to be green or white, There could be any number of reasons why we're on this pathway. But, something doesn't work as well as it should, or competes with something else, or it's a weird side effect or something. And all of that nuance in medicine is the hardest stuff to get in a structured medical record. It's the easiest thing to get in a note or a little conversation. But
right,
having people talk with each other and waiting for 2 people to be available while 2 other people try and set up the time and everybody's waiting on hold, that's crazy, right?
Yeah, well, and I think that's why it hasn't happened. I mean, and why the government regulators need to kind of force this issue. And I imagine you agree. It's just for what it is, right? The healthcare economics don't encourage clinicians to collaborate. They want to, because most of them are very compassionate people that care about their patients and want to provide the information so their patients get the best care. But there is no financial incentive for them to work with the neurologist, et cetera.
Value-based care, there's incentive, right? And not doing the same test twice is incentive. Figuring out that the mammogram was already done gets somebody a point. It might get both ends a point, right? Sure. Depending on how that was there, and just figuring out whether it was done or not, and having it with good provenance that it was done, not just I heard so, or Betty said so. Getting some record that shows it was done is how you get paid. There's the meaningful use now. PI incentives are pretty substantial on the sending end from a hospital to get the 2-way communication working digitally. 2 or 3% of your Medicare money from last year is pretty substantial. And so that's interesting. And now the final rule, or the condition of participation, CMS e-notification is the biggest piece of that that's hitting soonest. The other stuff is mostly later. Insurance companies have some stuff that's soon. Hospitals, sure. Patient things that are later, but the nearest term problem for hospitals in that final rule is this e-notification. And that's a condition of participation in Medicare. So at a minimum, it gets people worried. You know,
Yeah.
the other thing that we find, and we found it with essentially all of our customers, is that they may start by using CareMesh for notification or sending medical records. But what they find is that once they engage with the other end digitally, which happens the large majority of the time through a platform like CareMesh, once they engage with something that's real time and friendly and fluid and gives the other end tools like search and an ability to engage back and forth, then the other end gets more engaged with this hospital instead of the other hospital. So it becomes a competitive advantage, right? Every hospital working with outside practices, the outside practices can work with the other hospital or two also, right? And if mine is easier, stronger, better, more friendly, I can communicate better. You want to fire a question back to the PCP, the hospitalist, and say, why did you change the blood pressure med? And they'll answer. All of a sudden, you open up communication. You give them access to a real medical record that's now searchable. You know, the main vendors of EMRs do have medical records available for that doctor to log into. But that doctor has to log into 17 different hospitals.
Yeah, it's not scalable.
They have to have an account at the hospital, and their name has to be in the patient medical record. If both of those are true, then they could look at the medical record in that hospital. But doctors call it yet another portal. And you know, now we've got a fishing expedition going on to figure out what this patient sitting in front of me, who really thought she was at Mercy Hospital, was really at the other one, and you know, and I can't get the record or whatever. It's just too hard. So I think embracing push is an important thing. Getting hospitals to send things, which doesn't get in the way of, you know, we've really thought of fetch or pull as the key thing that everybody ought to be able to do. And it'd be great if it worked. But we've been trying for 30 years. It's not working, right?
Nope.
And one of the big problems is no hospital wants to open the kimono for all of its patients, for all of its competitors. But if they would push the right stuff to all of the doctors and the practices for just the narrow problem that they're trying to solve, this one patient, all of a sudden they've got both the best of both worlds. They're solving the regulatory problem, but they're also getting the feel-good part of it done. They're engaging the other doctor to feel good about their hospital and their you know, their quality of work with the other outside, and they don't have to worry about the competitive problem. So we think push and making push work 100% of the time is kind of an early way to go, and then engaging pull or fetch and making that work as well. But you know, we're not going to guarantee 100% in both directions to start with. But if you can push and make push work both ways, all of a sudden you've made a fetch. Right?
Yeah, that is interesting.
Yeah.
Well, I think your comments are really interesting, especially I just heard Judy Faulkner from Epic talking about how they were working on interoperability well before meaningful use even started. And then she shared anecdotally that she pushed it out to her customers. And the customer said, "Oh, we're not turning that on." And you know, so you know, we've come a long ways with interoperability. At least we're now having those discussions around, yeah, we should be doing a lot of this notification. I think there's still a lot of work to be done, but I appreciate you sharing those insights. And if you're watching this, be sure to go and check out CareMesh. I'm sure you can find it. Just Google CareMesh or caremesh.com. And also, if you want to find more great health IT content like this, be sure to check it out at healthcareittoday.com. Thanks, Peter.
Thanks so much. Nice to talk today.